morning, good afternoon, good evening to everyone on board. Thank you for joining us. Thank you for those that are still joining us. And thank you to the panelists and the entire Hardis Clinic team. My name is Anthony Kimathi. I'm the country director for the Hardis Clinic. With me on board, we have Executive Director, Dr. Jonathan Kyle. And one of our panelists is Dr. Paul Hart, a retired medical physician with very many years. I think it's more than 40 years of experience, 40 years of practice.
Unfortunately, you're right. Yes.
Yeah, I think it's an age. It's an age. He has practiced more than some of our ages. So he was practicing even when you were not yet born. So that's a privilege. That's a privilege to have Dr. Paul Hart here. He's a retired practicing physician currently. Solely and focuses a lot in internal medicine, family medicine, but he's a jack of all trades. So he has always been with us. He has always taken care of us whenever we need him. And he has entirely dedicated his time to the Hardis Clinic to make sure that most of the work that we do for you all and the communities that we serve does not go in vain or is not left out. He has always taken his time out to make sure that everything that we do is the right way. And it is done through the platform that we use, the telemedicine platform. He practices, I think, between Canada and the US, if I'm not wrong. But by extension and by default, he practices even in East Africa. So thank you, Dr. Paul.
Thank you.
We have Dr. Jonathan Kyle, who is our executive director, as I've told you. He has been our executive director for the last 1 year, 1 month. And by default, I will have to tell you that he's one of our founding members, and it's a privilege to have him on board. He has always given us room to grow this program and grow the programs that we have. I will give you a small overview of the programs that we have. I'm privileged to welcome a dear friend of mine, Dr. Mirriam, who is a nurse practitioner in Kenya University, and a nurse lecturer, works with different institutions, interested more in maternal child health and mental health and nursing education and research. So she has been a friend of mine for the last 1 year. We have worked together in different programs, and by default, she has always extended her hand in helping the Hardis Clinic in our work, and she will be one of our panelists during this meeting. The Hardis Clinic has been in existence for the last 11 years, but for the last 5-6 years, we have taken charge. We have taken root in different programs. We have 5 programs. The HIV program that is run by Felix, who is one of our attendees in this platform. And it focuses on adherence program. And we work in the Western Nyanza part of Kenya. We have the Girls and Women Safety Program that is led by Caroline in the coastal region of Kenya, where we focus in sexual reproductive health rights and gender-based violence and women rights, and more so teenage pregnancies in the coastal region of Kenya. We partner with CSO known as Hijabi Mentorship Program. We have another program that has been very productive in the IDP camps in Somalia. That is Beledweyne and Mogadishu IDP camps. And these IDP camps are run by 2 clinicians with an extension of 10 community health workers. And these community health workers mostly are embedded in the IDP camps. They assist in deliveries, they assist in mother and child health program. They assist in every part of the treatment and the taking care and management of these patients and mothers and children in there, and by extension, anyone that is sick in the IDP camps. The last that we have is the telemedicine program that covers the webinars that we have, and by extension, the global health education that we partner with different institutions 2 in US and 1 in Kenya, to train and work with different clinicians and students in different sectors in different parts of the country and in US. By extension, this is Vanderbilt University of Medicine and Pittsburgh Medicine School. I see Mirriam is getting in and out, so I will request you all to hear us out. We will try our best not to take you long. The webinar will not go past 1 hour, so we'll try our best by 9 we are done. The Q&A area is on the fifth icon on your tablet or laptop or screen. Please, in case in the midst of the presentation you have a question, please type it out so that at the end of it all, we will work on it and try our best to give you a response. If we don't give you a response during this meeting, we'll give you a response, an email response, a WhatsApp response, even a call if you wish. I will be there to do it. Thank you, everyone. I now present you Dr. Paul and Mirriam. The floor is yours. Let me share the screen. John, let me share my screen.
Mirriam's going to present, I believe.
Yeah. So Mirriam, since she concentrates more on, let's say, on nursing and palliative of care of most patients, she has a good understanding on the mental health, but the part that we will try and help Dr. Paul, you and I, is on the on the dosages of different medications. So in case Mirriam skips that and any of you has a question on that, please don't hesitate. Dr. Paul and I are here. Help out. Thank you. Mirriam, the floor is yours.
Okay, thank you, Anthony. So good morning, good afternoon, good evening, everyone. Thank you, everyone, for joining us today for today's webinar on diagnosing and treating depression, which is among the commonest mental health problems in Kenya today. As Anthony has introduced me, I'm Mirriam Kivuva. I'm a lecturer at Kenya Methodist University. I'm delighted to be here today as together we talk about a topic that we are passionate about so that we're able to improve mental health outcomes in our country and also beyond. I request this to be an interactive session, so feel free to share your thoughts, ask questions in the chat box as much as possible, and we'll be open to answer your questions just as Anthony has mentioned. So our topic today is depression screening, where we'll be looking at how can we screen and also diagnose and also manage depression in our primary healthcare settings, especially in the low and middle income countries, especially like Kenya. So we'll go on to discuss about the prevalence of depression. So the slides are not moving from your side. Can you hear me? Okay. So just as I've mentioned earlier, you find that depression is one among the most common psychiatric conditions in all health groups globally.
I think Mirriam has an issue from her side. Hello, Mirriam, are you
Anthony,
there?
can you hear? Yeah, can you hear me?
Yeah, we lost you a few minutes ago.
Oh, I'm sorry for that. I think my internet is unstable. I don't know why. And it's Safaricom.
You can go right ahead.
Okay, thank you. So just as mentioned earlier, depression is among the common psychiatric conditions that we have in Kenya today, and is usually common among health groups, but it is more common among the adolescents, whereby we find that when you look at the prevalences, the highest prevalence is among adolescents in Kenya today. And basically, it's also worth mentioning that when we screened patients especially the ones that visit our primary healthcare setting, we find that 42% of the patients that present will be screening positive for depression. So that means that we have a lot of many patients who are diagnosed, which now underscores the important role that we, the primary healthcare providers, especially the clinicians, have to play in ensuring that we're able to identify these cases in good time, and also we're able to institute management in good time. So basically in today's presentation, we'll be looking at how can we be able to screen depression using the different standardized protocols that we use, tools, not protocols, that we use in depression. We'll also be looking at how do we diagnose depression. And this basically underscores the importance of how we communicate to our patients, meaning that we need to be compassionate to our patients, we need to be judgmental to our patients as we conduct these diagnostic interviews. Meaning that when we are talking to these patients, we should be able to see beyond what the words are saying. Then we should also be looking at how we use the different screening tools. And these ones are standardized tools that we have been using every day. Like in Kenya, what is commonly used is the PHQ-9 that we use to diagnose our patients, but we have different tools altogether that we can use depending on the context and also the type of patients that we are dealing with. We'll also be looking at the criteria that we use to ensure that we institute the correct pharmacologic treatment, or basically different classes of drugs that we can use for our patients, depending on their presentation and also depending on the test that we need to do prior to instituting the treatment. Remember that depression can be caused by different causes. So it is always important to ensure that we do the prerequisite lab investigations and also to screen for other medical conditions that may coexist together, so that basically we're able to meet the comprehensive needs of our patients. We'll also be looking after we institute treatment. Remember that drugs that we use for depression, they don't work immediately. So it also is good to monitor our patients, reassure our patients that basically we are able to ensure that we improve their adherence. Then also, we as the primary healthcare providers, it's also very important for us to be able to recognize our capacity and at what point do we need to refer our patients.
Mirriam, we lost you a few minutes ago, a few seconds ago. Are you there?
Anthony, can you hear me?
Yeah, we lost you again a few seconds ago. But you can go right ahead.
Can I leave and rejoin again?
No, you can continue.
So the next thing is understanding the I cannot be able to see the slides from my side.
I think Dr. Paul, yeah, she has a...
Yeah, I think she's having problems. Can you hear me?
Yeah, I can hear you well, but she's having
Anthony,
problems.
can you hear me?
Yeah,
Yes,
we can hear you.
I can definitely hear you.
Can you see my slides, Mirriam? I think our network is not great. Mirriam, are you there?
Her microphone is muted.
Can I
Your
leave and
microphone is
rejoin?
muted.
Now, yes, we can hear you now.
We can hear you now. Can you see the screen? Mirriam, can you see the screen? Can you see the screen, my screen? Dr. Paul, I think we can continue from your side.
Okay, I'm sorry. I'm sorry Miriam is having a problem. Okay, when we're talking about depression, just to go over the first slide again, depression is a major problem worldwide. So it's not unique to Kenya, but it definitely does happen. And if you look in a general hospital, 42% of patients who come with a problem screen positive for depression. So when you ask them about symptoms that go with depression, almost half of the people experience it. So it's a major condition that we should be aware of and that we should definitely, treat. So the purpose of this is to go over how do we diagnose it? How do we treat it? And one of the data that I looked up before, or just recently, in Kenya, outside of the capital, there's only one psychiatrist for 1 million people, which means that the people who are listening here, our providers, are tasked with recognizing and treating depression. And that's in addition to taking care of the HIV, the TB, the malaria, the diabetes, the hypertension. So it puts an extra burden on people. But it's important because recognizing our mental health is so critical. So what we want to do is talk about how do we screen for depression? What tests should we consider doing? And then how do we start treatment? What should we use? Now, I hope that the medicines that I put down here are available in Kenya. Unfortunately, my database is the US. So I know you're going to have SSRIs available. I just don't know if it's the same what we have, but the concept is there. Next slide, please. Okay. What are the basis, the core symptoms? People are sad, empty, irritable. They lose interest in their daily activities. You're no longer enjoying being at home. You're no longer enjoying activities that you usually did before. You have trouble with sleep, and you can have both your trouble getting to sleep and staying asleep, that's insomnia, or you're so tired you feel like you want to sleep all the time. Your weight may change. You can go up or down. Your appetite can be affected. You can feel tired, fatigued. You can feel that you're just worthless. You're not contributing to your family, to your job, to society. You have trouble thinking. And you can also, if other people look at you, they may say, gee, he seems a little irritated. He seems a little slow. And when it gets really bad, you think of ending your life. And suicide is, I guess, the major risk for a treatable condition. And what I was taught, and the most important assessment we have to do is the patient that you think is depressed, is he at risk of committing, or she at risk of committing suicide? Because that is critical. You don't want somebody to leave your office or your clinic and kill themselves when we could have helped them. So you've got this whole core of symptoms, and you have to somehow separate that. For if you're told that you have cancer, if you're told that you're having your diabetes is affecting your eyesight or your heart or your kidney, common complications of an illness, yes, you're going to be upset. Yes, you're going to be sad. But this is over and above a normal response to what would be a news that you're getting, or one of your family members is suffering, or in this case, our patients. Let's move on, please. So, how do we screen? There is something called the Patient Health Questionnaire. And what I will do, I don't know if I have this here, but I will send out to Anthony a copy of this questionnaire so that he can share it with everybody. It's an international questionnaire. It's a bunch of questions that you ask the patient. And this is just a way of us saying, in a scientific way, is my patient depressed to the point where I have to consider treating it? It's more than I'm upset because you told me my diabetes is causing me a little bit of problems. It's depression. There are other tools for anxiety when it's combined with depression. But if you just do these few questions, that's the gold standard. And they're easy to ask. We have to ask them in a non-judgmental way, in a safe environment. Next slide, please. Okay. When we're screening for depression, it's really important that you make the patient feel comfortable. Not that we don't do it when somebody comes in with their elbow pain or their knee pain or their cough. Yes, we want to have a safe environment, but what you want to do is make sure that they feel comfortable talking to you. It's private. You're not talking in front of a whole other group of folks. And I don't know what the physical setup of the different clinics are. Where I was practicing in the United States, we took the patient into a separate room. You shut the door. They know that it's a private space. You let them know through how you're interacting that whatever they say stays in that room. You're not going to share it with anybody else without their permission. You go and you ask the major symptoms of depression. You're going to ask about their mood, about their sleep, about their energy, their appetite. And then you're going to ask about self-harm. And I would ask directly, have you thought of harming yourself? And if they say yes, then you move on and you say, have you thought what you're going to do? Because if they say, yes, I've thought that it's just not worthwhile living this way. But they say, no, I haven't any plan. I'm just so bothered by what's going on. It's different than they say, yes, I thought of going and throwing myself in front of a car, jumping off a cliff, hanging myself. Because I've had patients who committed suicide. And who you hope that the patient is giving you an honest answer. Not everybody does. You can't force it. You can get, as you watch the patient, you can get some indications whether or not they're being truthful with you. But it's really, really important that you ask how great the risk is. Because the only time, and I can't talk about Kenya, but the US, the only time I could violate a patient's rights and confidence if they said they were going to harm themselves and wouldn't let me help them. That's when I could call an ambulance and get them to the hospital to make sure they get immediate care. You don't want to send them out with a pill when they're actively going to harm themselves. Next, please. Okay, what tests do you do? It's nice to do a baseline set of tests to make sure that the patient is okay. Make sure they're not anemic. That's your CBC. It's nice to know that their sugar, their liver, their kidney function is normal. Is their thyroid off balance? Are they tired and weak and just losing all energy because they're hypothyroid? And what they need is you to supplement their thyroid. They may need something along the way to help them emotionally, but if that's the underlying cause, again, I mentioned liver and kidney, and if you're worried that the patient is abusing a substance, then it becomes important for you to do a screen. You're going to ask the patient, are you taking anything? But the other way of knowing for sure, because not everybody who's abusing a substance is going to tell us. Next slide, please. Okay. Let's say that you've reached a point where you've done your screen, you've looked at the test, and in your mind, this patient should be on an antidepressant. What do you use? First-line therapy are the SSRIs, the selective serotonin reuptake inhibitors. They've been around for many years. They're safe. They work we think by increasing serotonin levels in the brain, although there's some more recent studies that say, yes, they work, but maybe the underlying mechanism is not fully that, and there are other factors involved. Even if we were not knowing the full mechanism, these are very safe drugs. And these are US names. I don't know what they're called, unfortunately, in Kenya, but fluoxetine, the one here, Zoloft, the Lexapro, they're all well tolerated. And as you notice, as under the lax one, the Lexapro, it says minimal drug interactions. The providers in Kenya are seeing patients who are very, very complicated. HIV, TB, malaria, plus many other conditions. One of the worries is when we start any new drug, and it doesn't have to just be for depression, although that's our focus today. One of the major worries is that we could have a drug interaction with existing medications. So you need to be on something for your HIV. You need to be on something for your TB. Am I going to give you a drug which I think is going to help you, but is now going to interact with the drugs that you're already on? And I'm going to send to Anthony to send out to you, there is a free drug checker that is international that you can use to put in whichever medicine your patients are on. Now, if they're not on another medicine or just on something for their diabetes, I'm not as worried. But when you start doing complex illnesses like HIV, like TB with multi-meds, then you at least should consider doing this the first time out. Once you know it's safe, you do it. And when you start off on any of these medicines, my training has been start low. Don't start at the dose that you might wind up at, because if my patient is going to have a side effect, and if I use Prozac, which is the middle one there, and I start at 60 milligrams, that may be the dosage that they're going to wind up at, but they're more likely to have a side effect and a significant side effect if that's going to occur if I start at 60. If I start at 10, then we're going to know that the patient can tolerate it, and we're going to get that patient back under any circumstance to evaluate how they're doing. So if we start them at 10, it takes about a month, give or take, for the body to start seeing or the patient to start seeing a change. There are some rapid responders. There are people who start on these drugs and within a week are saying, I feel a little bit better. But the majority of people, up to a month. So if you plan on starting your patient on any of these three or any of the other ones that are available, that I don't know the name, I'm sorry, in Kenya, plan on asking them to come back to you in a month. At that point in time, you can say, okay, how are you doing? Oh, you're feeling a little bit better? Then you can decide with the patient, well, maybe if I increase the Prozac, the fluoxetine from 10 to 20, you may improve. And it may take a number of visits. And maybe by the time they get to 30 or 40 milligrams, if you go there, they say, yeah, I'm starting to feel like I used to. No need to go higher. But you gauge with the patient using the patient as your guide. Next slide, please. Okay, what are the side effects? What I always do for patients is I mention general side effects. I don't go into every side effect, but I let them know the common ones. GI symptoms, really common. Nausea, diarrhea, indigestion. Much less likely if you start at the 10 or the lowest dose. Sexual dysfunction, and that can be a significant problem for both sexes. Now, there is a solution. One, you can try a different drug, but I don't know if the Chinese herb ginkgo biloba is available in Kenya. It is an herb, and it has been shown to effectively help with the sexual dysfunction, not interfering with how the drug works, but it's a safe way of doing it. So if the patient is saying, I'm getting better, but the sexual dysfunction really is affecting me, ginkgo biloba, very safe option, and it's an herb with really few side effects. Again, sleep disturbance. You adjust the dose. For some medications like the Prozac, the fluoxetine, better in the morning. The other ones like the paroxetine, better in the evening. If you want to use melatonin to help for sleep, perfectly safe. Again, a little bit of activation or sedation, adjusting the dose can do it. And finally, weight change. Weight gain is sometimes a problem, but you can encourage people to do exercise, which is helpful for depression anyways. Physical activity is a viable thing to do, and to look at what they're eating. And, that's easy for me to say, coming from a place where food insecurity is not usually as major a problem as it is in some other places, but to do the best you can with what's available. Next slide, please. Okay. They suggest 2 weeks. I was usually 4 weeks, I find. But let the patient know that if they're having problems, come back to you sooner. Don't wait a month. If a week or into 2 weeks into the meds, they say, this isn't working for me, we can always make a change to a different medicine. And at the 8 or 12 weeks, so now 2 months out, we should be getting some really good results. You can repeat the depression test, that the one that you're going to be getting, very easily to see what the difference in score is, and to see, is your patient improving not only by what they tell you, but by the hard evidence of the test. And as it says in the bottom, open communication with the patient are key. This is different than monitoring the blood pressure, than checking for anemia, than looking at the blood sugar. I mean, that in one sense, yes, there's a dialogue with the patient, but not to the same extent. Here, you want to build up that rapport with your patient. They have to know that they feel comfortable with you talking about some very personal things. Our feelings are personal, and we don't easily share that with people. One technique that I used to use with a patient, and everybody's different, I never wore a watch in the room when I was with the patient. So I couldn't look at my wrist and give them an indication that, hey, this visit should end. I tried to be as calm and as caring as I was interested in my patients I could be. All these make the patient more comfortable so they can let you know how they're feeling. We're more helpful to them. Next slide. Okay. When do we make a switch? If they don't have adequate response. If the side effects are such that they can't tolerate it, or if they're getting better and you want to do something more to enhance, to improve their response. So yes, they did respond a bit, but not enough for us to say we're comfortable with how our patient did. So what we can do, we can go from one antidepressant to another one. People may respond better from one to the other. I'm sure you found that with blood pressure. So not everybody responds to the first medicine we put them on for their hypertension. Sometimes we have to add a second med. Sometimes we have to switch meds. So same thing for depression. Now, directly switching, you can do that. So it's usually better to do the tapering go down on one, go up on the other. And then the final, if you're really worried about the side effects, taper it down till it's really low, then make the switch. And what you have to do is look at the medicine you're using. And I'm sure everybody's familiar with this concept of half-life. When you take a drug, how long till half of it is gone in the system? And that depends on how our bodies process the medicine. Is it excreted in our urine? Does it go out through is the liver metabolizing it? All this depends. If it's a shorter half-life, that affects our dosing, but how fast we can make a switch. A longer half-life is such that we have to make a switch slower because that medicine is still hanging around and potentially could interact with a new med. Next, please. Okay, this is a nice slide with one psychiatrist for 1 million people outside of the capital. I'm almost wasting people's time because you don't have a specialist. And this makes it so much more difficult for the providers here. If you have treatment-resistant depression, if they start getting hallucinations, delusions, disorganized thinking, and you think that they're becoming psychotic. Complex morbidities. Well, if they have multiple psychiatric conditions, severe medical conditions, these unfortunately are a lot of your patients. So you are tasked with dealing with a really difficult group of patients. If they suddenly become suicidal, especially if you have a plan or they have attempted and somebody stopped them and brought them to you, this is where I refer somebody to a hospital so they can get inpatient care where they're safe. And specialized therapy, that's you guys. I'm sorry, unless there is a way to get them to the one psychiatrist for 1 million people, I don't know how that's going to happen. And I feel sorry for the tremendous burden that places on you. If you look at treatment-resistant depression, I don't know if ketamine is available in Kenya. Ketamine, if it is, given intravenously, is a very, very effective treatment for depression. But it has to be given in a supervised situation. It's given IV, usually in a setting where the blood pressure is monitored because it could cause hypertension. And the dose is based partly weight-based, partly symptom-based. There is an oral form of it, not and a nasal form, not considered as effective. And there's one final way, and I don't know what's available. It's called TMS, which is a magnetic stimulation of the brain, which has been shown to be effective for depression, especially in adolescents and younger people. And that is non-medication. That's done with a special device where a magnetic pulse is pulsed into the brain over a series of, I think it's 15 or 20, I'm not sure, treatments, and it has been shown again to be effective. Now, these are alternative therapies. I don't know what's available in Kenya. I can get information if anybody's interested in it. And if ketamine is available, that may be something that you may want to consider using because it is a nasal spray. It's not as effective as the IV, but in a regular clinic, when you don't have to have IV therapy, a nasal spray administered by the provider with the patient being monitored is something that you may want to look into. Again, I can get you the information. No idea cost basis, no idea regulatory basis in Kenya. So I'm not trying to please skip any regulations or violate any of the the guidelines that you operate on, just to give you the information. Next slide. Okay. we have to educate our patients. Talk to them about the importance of staying on medicine. And that's no difference for psychiatric meds as your diabetic meds, your HIV meds, your TB meds. It's so important. And as you know, or you may know with TB, what was started years ago is direct observation of the patient taking the TB meds to prevent drug-resistant TB. The patient would be given the med by the nurse or by the worker and watched while they swallowed it. And the incidence of resistant TB went way down. We don't have to do that with this med, but it's really important that we tell our patients how critical it is to take the meds. We have to be realistic with the patient. No, you're not going to be better after the first few pills. I've had patients call me back when I'm treating a pneumonia or an ear infection. Doc, I've taken 2 or 3 pills and I'm not better. And, we can smile about that, but we have to let them know for psychiatric problems, we're talking up to a month. Some people sooner, but we're talking up to a month. And suggestions to them of what they can do as well as take the meds. Exercise, trying to get good sleep, looking at their diet, looking at interacting with other folks. Now, the next here it says adjunctive psychotherapy. Before this lecture started, I talked to Anthony. There's a wonderful program developed in Kenya for helping people with psychotherapy. I'm sorry, I don't have the name in front of me, but I will send it there. It is supposedly really easy, very effective, Kenyan developed. So it is for Kenya with the background of your health system, and it was developed a number of years ago. I will get that link for people if they want to look into it. And that's something that you could consider for your patients. And then the other thing is support networks. Years ago in my office, what I did is I was getting medical samples for a medical clinic. And what has to happen is we have to take the samples, open them up, repack them. So I went and I asked some of my patients to help, but I chose patients that were alone, needed support from somebody else. They didn't know I was doing this. So I had a group come in once a week, and they sat down at the end of the office hours, and there were 6 or 7 of them, and they were doing this. But over time, they developed a wonderful support network. And they made friendships outside of this. So suddenly they had a group of people. So if you can get those people who need support to do something for you, it doesn't have to be major. Could you please come in and help do something that is safe, that is not confidential for our records? You can build a support network for people without telling them what you're doing. And I'm not trying to hide something, but it's a nice way of helping people, because if you have a support network, you're going to start feeling better. You have somebody to turn to and talk about your problem. You have somebody to turn to help you through a difficult situation. So that's just one suggestion of how to help with that. Next, please. That's it. I'm sorry, Mirriam, that you couldn't present. I know you would have done a better job than I can, but maybe next time we'll get your computer working. If there's any questions, I will gladly try and answer them. And also, any question that are there that I don't have an answer for, I will definitely go and provide that answer for you.
So thank you so much, Dr. Paul, and thank you for everyone that has been with us up to now. I talked to Mirriam offline, and she told me that she will be willing to, she's currently using her phone, and she's okay trying to go through the Q&A together with you.
Oh, wonderful.
So,
That's perfect. Thank you so much.
so Mirriam, you can unmute for yourself and we can try, you're on mute. You're still on mute, Mirriam. We'll try and see whether these questions, we'll try and answer as fast as the next 10 minutes. The first question, I think, was what should we do with patients who don't want to take their medications?
Mirriam, do you want to pick that up first?
Yeah, I'll gladly do that. So for the patients who are not willing to take their drugs, I think the first thing we as the healthcare providers need to do is knowing the why they are not taking the medication so that you're able to address the specific causes why they are not doing it. Secondly, you should also be able to do a lot of medication education and counseling on the same for them to understand where they are taking the drugs. And also what we have said before, that we need to tell them that these drugs do not work immediately. These drugs will take some time. So basically, so that they are patient enough. And also, we also need to educate them on the potential side effects that they expect so that when they experience these side effects, they don't, basically, they are aware of them and they are not anxious, or basically, that does not cause them to stop taking the drugs. Thank you. You can add anything that I've not mentioned on the phone, kindly.
No, I agree. Sometimes what I also do is I say to the patient, okay, I understand you don't want to take medicine. You've told me how you're feeling, and we've done the screen, which is going to our next question. What do you want to do, or what are you prepared to do to feel better? And put that back to the patient. So we can get an indication what the patient's, because then we could say to them, okay, we can do that, but what happened, then say to them, but it's been shown that if you take these medicines, you could feel better sooner. Is that something you want? We're not going to convince everybody. And I actually had a patient.
I think.
Sorry.
Okay, go ahead.
No,
Go ahead,
say,
Dr.
I
Paul.
actually, I happen to do telehealth here into the States to a population who don't have insurance. And I had a patient the other day says, I don't want to take drugs from the big pharmaceutical companies. And, yet she had migraine headaches where the medicines have been shown to help. And so I said, okay, here's your other options, what you can do. But if you want to suffer, I didn't say it in those direct words, that's your choice.
Yeah, I think this question actually comes in the setting of the culture that we live in, and most of the patients that we see, some of them have this notion that if they are diagnosed with any sort of a mental health condition, it stigmatizes them to their friends, relatives, or anybody that they come across. So it has been a common concept where mental health conditions are shunned away and hidden from relatives, from friends, or anybody that may come to realize that you're depressed, you have bipolar condition. So it's common to see patients ask you, what does this medication do? If you point towards depression or any sort of a mental health condition, they will start backtracking and thinking that now you have started going overboard, diagnosing a condition that they think may stigmatize them to their friends and colleagues or to their relatives. So to me, I think most of the work that you can do is to make sure that, as Mirriam has said, talk to them, get an understanding of where they come from. Even if it's from their cultural background, try your best to make sure that you talk to them and get an understanding where they come from. And then join them there and try and talk to them, because most of them are so lost that you have to at least try and retrieve them by talking to them first, and then get to a point now they get an understanding of why do you think this is working. The next question, even to Mirriam and Dr. Paul, And this is common, Dr. Paul, in our patient departments where we see, I think he or she was writing, we see a lot of patients. How do we easily tell someone may be depressed? So you have a line of patients that are coming in and out. And most probably the mental health condition or the depression is not the first diagnosis or the first case, but you come across and think that this may be depression. How do you go about in an outpatient setting where you are seeing 50, 30, 40 patients and you have to sit down with this patient? Mirriam?
So thank you, Anthony, for that question. So in outpatients where we are seeing so many patients, I think it's a wake-up call for us, we as the healthcare providers, to be active listeners. We should be able to listen to our patients. Basically, we should be able even to pick what the words are not saying. Most of the time, we're in a hurry, we want to clear the queue. So most of the time, we don't have that time to listen to the patient. Because remember that the more you listen, the more information you're able to gather from the patients, and also the more they'll open up to you. The second thing is also being observant, whereby we want to be able to recognize certain patterns or certain behaviors or certain series of complaints about the patient or basically the patient is presenting, and then we're able to pick up these cues that can be pointing out that this patient is having depression. Remember that most of the time we're in a hurry, so just a little vigilance or being more observant, you may be able to pick these cues up. We can also employ the rapid tools. For example, we have talked about the PHQ2, which only requires you to ask 2 questions. So by you asking those 2 questions, they'll enable you to be able to pick a patient quickly who you can be querying that they may be having depression. In that, in the outpatient department, we don't have the luxury of time. You cannot use the PHQ9. So those 2 questions, it only takes a few seconds. So those few seconds can help you pick a case. Thank you.
Excellent answer.
Thank you. Great answer. Thank you. The most common medication that we use in our outpatient departments is amitriptyline. I think this is a tricyclic antidepressant, Dr. Paul. It's not an SSRI, and I think it's the most common medication that is given over the counter in our setting. Is there any side effects or for the long-term use of them?
Let me look that up. I know the short-term adverse reactions, which are numerous, as everybody knows, but let me find out about long-term, and I'll write that back for you.
Thank you. I think that question was going to Dr. Paul. Mirriam. The next question, I think I will forward it to Mirriam too. What's the most common age that gets depressed? I think this question is broad and it covers, I think let's answer it, if Mirriam is possible, let's answer it in the LMIC.
Okay, I think in the LMIC context, the most common basically age group that has depression is the young adults and also the youths and the adolescents. And basically, basically in the statistics, we say that the adolescents is very common because at that point in time, they have poor coping mechanisms in terms of the life stresses that they may be having. That's why you find that adolescents have high cases of depression, and some of them proceed even to committing suicide, which is very unfortunate. So I don't think, have I answered
Paul,
your question?
I think it is answered. Dr. Paul?
Yes, I think she's right.
Thank you. The next question, Dr. Paul, this goes to you. Is ketamine addictive?
It has some addictive properties, but used properly, no, because it's going to be given, over at specific intervals by a provider. And I don't know I don't think it's available on the street, or if it is, I'm not aware of that, at least here in the States.
I think
so I'll double check that, but no.
It's not that common in the East African context, and I think the Kenyan context by far, because it was if I'm not wrong, it was previously used in anesthesia in theater. but I think it was stopped. But I'm not sure. It was common. It was common in theater procedures.
Yes.
But currently it's not.
So is it legal in Kenya
Yeah,
now or
it's
no?
legal. It's legal in Kenya, but mostly under what we call dangerous drug. It is there. It is mostly in the dangerous drugs category.
Okay.
Yeah. The next question, I think we will try and work with these for Dr. Paul and Miriam. What is the difference between depression and bipolar?
So I think I
Miriam?
can go first. So for depression, is basically where we have talked about this patient is having persistent low mood, lack of interest, among other symptoms that we have talked about. But when we talk about bipolar, just bi means two, meaning that this patient is presenting with two things at the same time. So this patient is oscillating between depression and mania, whereby in mania, we're talking about a patient being euphoric, having elevated moods, and then at certain times they change again, they get depressed. So we have two things coexisting together, but both are mood disorders.
Dr. Paul?
No? Excellent. I'm comfortable.
I think there is an additional thing is that on treatment of depression, we use, as Dr. Paul talked about, the antidepressants, the SSRIs, the tricyclic antidepressant, and now in bipolar, the most common drug is mood stabilizers. So there's a difference in that, and then the mood range. In the mood range, we have mostly the depression part is a unipolar. We call it a unipolar, only low moods. They don't in
Right.
depression. They are always on low moods. But now, as Miriam has talked about, in bipolar, it's two, where we have the highs and the lows.
Yeah. And
Thank
you're
you.
using
I
more than
think,
one med often.
yeah. Uh, Felix had a question. When should we wean off a patient from antidepressant? A very good question, Dr. Paul.
That's an excellent question and a difficult answer. Sometimes it's the cause of the depression. If it's a situation that has resolved, um, and the patient has done well on the antidepressant, you can start tapering it down and see how they do if they're starting to slip back. I would never stop it suddenly. And indeed, there's a syndrome, the serotonin syndrome. If a patient suddenly stops some of the SSRIs, and since that is the most common drug here in the US, not amitriptyline, although it's available, of course, you want to make sure that you slowly taper the medicine down and see how the patient is doing. If the patient comes back to you and says, I'm starting to feel a little down again, we're too soon. It also, I think, depends on the cause of the depression. Depression, at least my practice, in some families, it tends to be depression ran as an illness. It was and in those patients, they may have to be on it for years and years. We know it's safe to be on these drugs because they've been out now, what, 20 plus years? And we know the patient can take them safely for that period of time, but you have to assess how the patient is doing. You know, we don't put a patient on an antidepressant, they're feeling great, they come back, 2 or 3 months later, doc, I'm doing beautifully, thank you very much. We don't stop it because you want to be sure that the reason they are doing well is because not only because of the medicine. If there's an underlying biochemical reason, um, then we want to make sure we keep them on that med. So it's not an easy answer. It's having a dialogue with your patient and seeing how they do. Are you there? I think I blanked. Hello?
Like looks like Anthony froze.
Yeah, I think everything froze. Are are we finished then? Because I
I
lost.
think he just lost his connection. So yeah, so I guess there's a few more questions left. We are past time. Um,
I can go and answer those and send them an email, I can answer. I've got a list of the questions. I copied them.
mhm. Great.
Whatever they want to do.
So maybe we'll do like one or two more, then the rest of them we could
Okay,
finish
sure.
later. So the question about
Is
what,
anybody there now?
yeah, there's still people there. We've had a few drop
Okay.
off, but
Okay, super. Great. What's the next question then, please?
um, what informs the choice of antidepressant for someone with depression? How do you choose which antidepressant to use?
The question is, which interpreter do we use? Partly is what's available, because as one of the doctors kindly let us know, amitriptyline is the drug of choice, I guess, for part of the folks in Kenya. That becomes the agent you use. In the States, and I know it's different, SSRIs are first line therapy. So it's basically based on one, what you have available, and then two, when you start off, as we talked before, if the patient doesn't seem to respond for first line therapy, then you have to reach out and find out which other medicines are available for you to prescribe to your patient. So it's not a great answer, but I think it does give you some answer.
Great. There is a few more questions. We are past time, so maybe we will wrap it up here and we'll have you
Yeah.
respond to all
Okay,
of the
yeah,
different
I'll
questions.
respond. I'll get the.
Somebody asked if you could have the slides,
Oh,
and
yes,
those we
the slides
provided.
are available for everybody. We always do that. And if you could let Anthony or Felix know, please, we need suggestions for the next talk. What I want to make sure that the talks are meaningful to the providers that we're helping. So please give me some suggestions so I can go and research and try and help provide the most, worthwhile discussions that we can have that will help you with your patients. Because I don't want to give you something that is not of value to you. That's just not worthwhile for you.
Great. So when I'll ask Anthony when he sends out the slides and the answers to the questions that he
Right.
does ask all the attendees if they have any topics. So be thinking about it. And if you have something, please respond back to Anthony with that, and we'll try to line that up for one of these future months.
Okay. Thank you very much. And thank you for helping with moderating there.
Yeah. Mirriam, thank you so much. It's always great to have you involved and sharing from your extensive experience in clinical work. And thank you, everybody, for attending and for the active conversation and questions that you have brought up. And thank you, Dr. Hart, for your time as
My,
always. We appreciate it.
my pleasure. Have a great day, everybody.
Bye, everyone.